Hello, let's learn about antimicrobial stewardship, how to take steps to reach the summit of antimicrobial stewardship. Let us learn about the antimicrobial stewardship. It refers to a set of activities which is designed to promote the selection of optimal antibiotic drug regimen, including dosage, duration, and route of administration. Why is antimicrobial stewardship required? It is required to tackle the increased burden of resistance. It is required to improve the rationing of antibiotics. It is required to improve infection control practices in hospital. Up to 50% of the antimicrobial prescriptions in Asian hospitals are inappropriate. CDC has called on all hospitals across the country in US to have stewardship implementation in their healthcare settings. Likewise, Asian too needs to have similar AMS programs in their settings. AMS is an important tool to improve antimicrobial usage, optimize the infection control practices, prevent antimicrobial resistance, and decrease the antimicrobial toxicity and reduce the healthcare costs. Now, what are the basic? First, to perform a SWOT analysis, that is situation analysis, obtain approval for the activities, assemble the AMS team, set goals, select interventions, select key performance indicators, implement, educate and train, and monitor and report to program. What do you understand by SWOT analysis? It is a strength weakness approach to challenges analysis, wherein we determine what policies, resources, and systems are already in place to optimize antibiotic usage, assess the hospital situation in relation to areas of antibiotic usage. Then after approval from leadership for AMS activities, after a formal statement for support and secure funding for the AMS activities, work within the hospital budget and personal constraints to create the most effective multidisciplinary team. Set goals. Set manageable goals based on findings from the situation analysis. Goals can be focused on specific units, infection syndromes, specific class of antibiotics and resistant bacteria. Then upon this set interventions. There are many potential AMS interventions, any combination of which can be used in AMS program. Decide which intervention will achieve the AMS program goals and are most supported by clinical staff. Select the key performance indicators before implementing the program. Select measures to evaluate the effectiveness of the AMS program. Also consider assessing outcome measures such as length, hospital stay, AMS trends, and antibiotic expenditures. And implement, educate, and train. Strategy to rule out of interventions. Make sure the treatment guidelines and hospital antigrams are easily accessible. Consider using the intranet, pocket guides, ward posters, and provide alternate summaries. Monitor and communicate the AMS program progress and success. After implementing the chosen interventions, begin monitoring the AMS program processes and outcomes to assess the impact of the implemented interventions and identify opportunities for improvement. Instead of continuous surveillance, consider less resource-intensive pipeline surveillance to monitor consumption and AMR. What are the core components of the AMS program? Leadership commitment, accountability, drug expertise, action, tracking, reporting, and education. What is Effective leadership is vital for the success of the AMS program. Ideally, an ID physician should lead the AMS team. If the ideal leadership is not available, and this role can be filled by other members. Formal ID training is beneficial, but not absolutely necessary. Team leaders need to be assertive and effective communicators who are familiar with stakeholder needs, use evidence-based knowledge, and are respected by hospital administrators and medical staff. What does the AMS structure look like? It looks like a team that consists of pharmacist or ID physician or clinical microbiologist, infection expert, IT expert, other physician, pharmacist, nurses, epidemiologist, hospital administration, and clinical pharmacist. What are the roles and responsibilities? It includes for pharmacists, it includes develop and implement the AMS program, sustain the AMS program. For the administration, a representative the role is to provide formal support and provide resources for the AMS program. For the pharmacist co-leader, it supports a team leader and responsible for daily AMS tasks. Microbiologists provide diagnostic support. IT experts provide, develop, implement, and maintain the IT system. Infection control professional role is to provide infection control support and share the infection resources. The key physician, pharmacist, and role stakeholders is to provide input during the development and implementation of AMS initiatives, provide support for daily AMS tasks. Non-ID pharmacists can improve the knowledge of ID or AMS related issues by becoming familiar with the clinical practice guidelines, making use of the educational resources, attending rounds, visiting institutions, and completing a certificate program. Nurses can improve the knowledge of infectious diseases or AMS related issues by US CDC guidelines, American Nurses Association guidelines, free online courses, and visiting institutions. Interventions that are important in establishing AMS in the hospital settings. It includes developing the guidelines, for antibiotic policies, pre-authorization of antibiotics, prospective of prescription audits, IV to oral conversions, and dose optimization. Because pre-authorization, it means antibiotics requiring pre-authorization needs to be carefully selected based on variables such as broad spectrum coverage, potential to promote resistance, potential for overuse or misuse, risks of serious adverse effects, high cost, and need to reserve for treatment of multi-drug resistant infections. The prospective audit and immediate feedback systems include selection and identification of patients, primary review by the clinical ID pharmacist, secondary review and evaluation of cases, optimal antibiotic usage such as choice, duration, dosage, duration, route, database entry and data analysis, and accordingly the interventions. Now, how to develop the guidelines? It includes identify the most important disease syndromes, identify integrate the care bundle guidance of the specific clinical symptoms, evaluate the most common pathogens, evaluate the effective antimicrobial agents that are available for the treatment of the specific clinical syndromes, and prioritize them. Integrate all the above information into a table and an algorithm. Emphasize the importance of considering the patient factors, the metabolism pathway, and potential drug-to-drug interactions before deciding on the treatment plan. And some general principles of antibiotic usage needs to be considered, such as what is the diagnosis, what is the risk of infection, does the patient have antibiotic allergy, how severe is the infection, is the patient immunocompromised, and what is the status of the patient renal and hepatic function. The de-escalation protocol needs to be in place. If the hospital's empirical antibiotic treatment guidelines have not been followed, but at a valid reason, the pharmacist should recommend that prospective antibiotic therapy needs to be de-escalated. During empirical therapy, a narrow spectrum antibiotics should be chosen in accordance with treatment guidelines. Once microbiology results are available, the pharmacist should encourage this change to definitive therapy with as narrow a spectrum pathogen treatment as possible based on culture and sensitive results. Then there should be a criteria for de-escalation of broad spectrum antibiotics used by pharmacists. The criteria for de-escalation for empirical therapy includes temperature less than 38, not an inotropes, suited to be written to baseline more than 100, not mechanical ventilated, respiratory than 25. And then in this day, the definitive therapy includes based on culture and sensitive result of the de-escalation from broad to narrow or IV to oral. IV to oral is a relatively simple interventions, and so it should be encouraged because oral antibiotics have good bioavailability in eligible patients. For example, fluoroquinolones have highly bioavailable drugs that can be easily converted from IV to oral. The advantages of oral therapy include ease of administration, early discharge of proteins, decreased IV-related adverse events, and drugs. Dose optimization consists of pharmacy expertise in relation to pharmacokinetic and pharmacodynamic principles. Dose optimization can be implemented by pharmacists on identifying basis of deviations from the recommended dosage, and critically ill patients, dose optimization by therapeutic drug. Why do we need an antibiogram? To know the susceptibility pattern of the hospital, to strengthen the AMS practices by utilizing the antibiogram for tracing resistant patterns in hospitals. Now, what is an antibiogram? It is similar to a report which highlights the susceptibility pattern of the different pathogens against different antibiotics in the health setting. It is capable of depicting the susceptibility pattern across the hospital over a period of time. It is an integral guide the clinicians in selection of antibiotics, develop hospital prescribing guidelines, monitoring the trends over time, identify the disease outbreaks, compare resistance rates across institutions, provide rational and plan and evaluate patient demographics, specimens, and pathogens, and antibiotic susceptibility information are used to generate an antibiotic. Key performance indicators in the stewardship program help to evaluate the level of progress, track the performance levels in respect to. And this includes for the process KPIs include antimicrobial consumption monitoring in terms of defined doses, days of therapy, and length of therapy. While the appropriation of antibiotic usage is monitored by adherence to hospital guidelines and rate of acceptance of interventions. The outcome KPIs include the rates of antimicrobial resistant infections, clostridium difficile infection rate, then length of stay, readmissions, and antibiotic exposure. Recurrent days of therapy, it is the number of days that the patient receives at least one dose of an antibiotic, some for each antibiotic. It requires patient level data from electronic health records. Defined daily doses is the total number of grams of an antibiotic purchased, dispensed, or administered and defined by WHO defined DDD. Length of therapy denotes the number of days a patient receives antibiotic therapy, irrespective of the number of antibiotics administered. Regarding a point prevalence survey, it helps in assessing the appropriateness of an antibiotic therapy on a particular day in a ward or across hospital. Length of stay is relatively easy to obtain. It can be used as a measure of clinical improvement and can be used instead of hospital length of stay. Antibiotic expenditure is the financial impact of AMS programs and that must be measured. AMS programs must focus on high-profile antibiotics, multi-drug resistant organisms, patient population, and hospital locations. It must create graphs, display the trends over time. Comparison of both interventions both before and after implementation of AMS program must. The most important is sustainability. Team leaders are responsible for the sustainability of the program. It involves monitoring and reassessing the AMS program performance, reporting the performance, modifying and adapting the program, continuing the education. Pre-specified process and outcome measures should be tracked to assess the performance of the program. For a sustainable program, long-term trends are as important as initial change. Modifying and adapting the AMS program, it involves AMS team leaders must stay up to date with the latest guidelines and treatment guidelines. The team must also agree to modify and add AMS strategies as appropriate. The team leaders will work with the microbiologists and pharmacists to add rapid diagnostic testing to conventional culture guided review. Regular meetings should be scheduled with the AMS team and clinical staff in the areas of the hospital most affected by the AMS. To summarize, AMS is a set of activities designed to promote the selection of the optimal antibiotic drug regimen, including dosage, duration, and route of administration. AMS is required to tackle the rising antimicrobial resistance, promote rational antimicrobial usage, and improve patient outcomes. It can be established by following steps such as doing the SWOT analysis, forming the team, setting the KPIs, setting the interventions, setting goals, educating, and monitoring. AMS can be successfully sustained by monitoring and reporting to development of antibiograms adhering to the KPIs, pertaining to antimicrobial consumption, appropriateness of antibiotics, and various microbiological outcomes. AMS can be achieved by leadership support, team effort, and determined mindset across the hospital. That's all. Thank you.